can now see our first slide, and you should now be able to see pictures of all of us who are here this morning. Thank you very much to our speakers. The format this morning is going to be 3 sessions. Dr. Claire Van Hamel, who's a consultant anaesthetist, associate postgraduate dean and foundation school director in the Severn region, who has published about preparedness for FY1 and has a particular interest in that subject and is going to be giving us a talk. Then I'm one of the medical legal advisors at the MDU, and Dr. Laura White, who I'm delighted to welcome, who's a lead clinical lecturer on the one-to-one medicine masterclasses and courses, so you may be familiar with those names. Thank you to you, our speakers, for joining us. You'll also see Dr. John Dale Skinner, who's one of my colleagues here at the MDU, another medical legal advisor, who's going to be collating questions. So please put your questions in the chat. We won't be reading out your names, so feel free, please, to ask anything. And we will come to your questions as we can at the end of all 3 talks as a panel. So please ask lots of questions. Also, you'll see pictures on screen of our 2 special guest final year students, Hannah Gleeson and Aqua Asif, who've both just passed their finals and, like you, will be starting their FY1 in just a few short weeks. So I'm very pleased to be able to welcome you all. Before we move on to Dr. Van Hamel as our first speaker, I just wanted to ask a question of you all as our audience. So you should see a poll question coming up asking you how prepared you feel for FY1. Do you feel very prepared, quite prepared, or really not prepared at all? So please do give us your votes. And while you're deciding, I thought I'd just come to Aqua and Hannah just to ask a little bit about how prepared you feel. And I should say that pretty much everybody last year, I think, didn't really feel very prepared. Hannah, I know it's daunting when you've just qualified. Congratulations on such a great achievement of qualifying. How do you feel about going into your first foundation job?
Thank you. Yeah, I feel pretty nervous, to be fair. But I'm staying in the same region as where I went to medical school, so that makes it a bit less daunting.
Yeah, excellent. I'm glad that that's a bit less daunting, and it sounds like you've had some other sort of opportunities with some shadowing and so on to help you feel better prepared. Is that right?
Yeah, so the medical school's organised a shadowing period in the first job that we're starting. So yeah, it's 3 weeks shadowing the F1, doing the job, which has been really useful.
Yeah. And one of the things we were talking about when we were preparing for today was the impact that the pandemic's had on training. And I know it really disrupted some of your placements. But in terms of the sort of practical skills, not just the sort of specialty specific things, one thing we were talking about is that there may have been fewer visitors on the ward, fewer family members than you might have come across otherwise. Does that mean that speaking to family and things is something you're a bit less familiar with?
Yeah, definitely. I think I've done it one time in medical school, which is obviously not ideal.
Well, it's something that will come on in one of the talks today, in my talk, so hopefully that'll help a bit, and I expect you're in good company. I expect almost everybody feels the same. Thank you, Hannah. Aqua, congratulations to you too. Dr. Asif, congratulations, it's a great achievement. And I know that you're not going to be working where you've been training, but you're going back to a region that you know pretty well. Does that help you feel a bit more prepared, do you think?
100%. Like the fact that I know the area like the back of my hand, because that's home, for me helps, I guess, with not, I guess, the preparedness, but I guess I feel much better. Like I'm in a better place.
Yeah.
And I think what has helped me, feel more prepared is we've a lot of the F1s, a lot of the junior doctors, we've already got like little group chats, and we found, I think, another 20 or 30 of us that will all start at Royal Surrey, and we've even made a little spreadsheet of like what our first jobs are. So it's nice in a way.
Yeah, that helps, that sense of support, doesn't it? So that's really good. Thank you. I wonder if we could look at the answers of the poll question now and see how prepared our audience feel. Thank you very much, both of you. And I'm going to be coming back to you after the talks to see if you want to ask any questions. So the poll result I can't see on my screen at the moment. Let me just see if I can. I don't know if anyone else can see it.
We can.
Well, in that case, Aqua, you can tell me what it says. I don't know. I'm definitely having some technical problems here and I can't see the poll results. How
So
many of your
3%,
colleagues feel well prepared?
of course. So 3% feel very prepared, 81%, so the vast majority feel somewhat prepared, and 15% feel not at all prepared.
Okay. Thank you. Well, congratulations to that 3% of you. I'm glad you feel very well prepared. The rest of you, obviously in the huge majority, not feeling terribly well prepared or quite prepared, but not. So hopefully the next hour or so is going to help you. And without further ado, I'll hand on to Dr. Claire Van Hamel for your talk. Thank you very much, Claire.
Thank you. So yes, I'm an anaesthetic consultant by trade, but I've been the Severn Foundation School Director now for over a decade. And one of the things that I did early on in my role as a Severn Foundation School Director was with a small group of colleagues, we thought it would be a really useful idea to try and introduce a week-long shadowing period, and it probably seems quite remarkable to many of you that a decade or so ago, actually, the shadowing period was a day. And so when we put in the bid to get a week-long shadowing period for all the people in the Southwest, we were told we had to do some research in order to justify why they would be spending this amount of money. And at the time, it seemed a bit of a nuisance when it seemed such an obvious thing to be a benefit, but in reality it enabled us to demonstrate that having a shadowing week is a very good thing, but also started quite a long period of time collecting data, which has enabled me to sort of research into the preparedness to practice, which has provided lots of interesting facts which have been used not only by us in Severn but nationally. And the outcome was that they then agreed to fund the week-long shadowing that you all now experience. Next slide, please. So yeah, as I say, I've been doing these surveys for over a decade, and I'd encourage you when you start your F1 posts, when you get the email, instead of thinking, oh no, what a nuisance, a survey to fill in, that you fill in that survey, because we try to use the information that we gather to improve your F1 lives for future colleagues. So as I say, do spend the sort of 10 minutes or so that we ask in terms of filling in the survey, if possible, please. Some of the things that came out of the very first survey that we did, sort of, I found quite sort of surprising, really. And one of the things that was clear, that people weren't being shown around the environments in which they were going to be working. So one of the sort of now expectations, which is written into the guidance for the shadowing period, is that all of the incoming F1s will be given a tour of the hospital and the department in which you're going to be working in. Obviously, that makes sense in terms of being able to find the right ward, the right locations and everything, but it also makes sense in terms of where is the canteen. In the very first survey, one of the respondents fed back that they were a month into the job, they hadn't been shown where the canteen was, and they were now too embarrassed to ask where the canteen was. So just think about that week-long induction. That's your chance to ask any questions that you don't know the answers to. You can carry on asking questions after that, but really in that first week, people understand you haven't often worked in that location before. You aren't going to be familiar with any of the staff, you aren't going to be familiar with any of the equipment that you're going to be working with, or likelihood is. So just feel free to ask. Say it's the best possible time, much rather that than suddenly finding a month into the job that you don't know where the canteen is and you're starving hungry and daren't ask anybody where to get some food. Think about the time that you can spend with the outgoing F1. It's your last chance to be a student, really, and say it is really imperative that you use the opportunity to get as many top tips as you possibly can from the F1 who's leaving. They'll have learned all sorts of shortcuts and sort of useful bits and pieces that it takes a long time to try and gain all those all that knowledge if you are having to do it from scratch. But if you take the opportunity to get those top tips from the outgoing F1, it will make life much simpler for you. The thing I think is probably most important is to get your passwords and access to the IT systems as soon as possible. So much of what we do in hospital now, the prescribing, the electronic discharge summaries, a lot of places have electronic notes nowadays. If you can't access the system, then you can't practice. So try as early as you possibly can in that week shadowing period to get access to the IT systems and start using them. You can watch someone do something on IT, but actually unless you're doing it yourself, you're not really gaining that muscle memory, and it's much better to spend a bit of extra time learning how to do these things in that week rather than in the next week sort of panicking over how on earth am I going to do X, Y or Z. Next slide please. The equipment changes all the time. When we have a new piece of equipment, there are little quirks to it. Don't be embarrassed to ask. If you haven't used something before, it's much better to ask than find that you've made an error and set up an infusion pump or sort of something similar incorrectly. From the point of view of patients, if you don't know how to do something, if you take blood and put in the wrong tube, then you're going to have to bleed them again. It's much better to say to someone, oh, is this the right blood bottle? Is this sort of where I should be sending sort of this sample? Make sure sort of samples are labeled correctly, otherwise you get a lot of samples coming back. They won't process samples unless they're labeled correctly. Things like that actually impact on patient care quite significantly. So as I say, familiarize yourself with all the equipment, however straightforward. If you're not sure how to use it, then just ask. It's not embarrassing to ask. It's much more embarrassing to find that you've got to go back to the patient and say, oh, sorry, can I take that sample again? I labeled it incorrectly or I sent it to the wrong place. So as I say, don't be embarrassed to ask. Much better to get it right first time if possible. All the F1s in England should be getting 2 hours of self-development time each week now. That's mandated in your contracts. If you're going to one of the devolved nations, I think they are slightly variable, but I think they are all introducing self-development time. I think it's an hour for F1s and 3 hours for F2s at the moment, but as I say, that may change. But basically, if you're in England, you're definitely entitled to SDT, and if you're in one of the devolved nations, it is likely you will be getting some self-development time. So try and identify where it is in the rota and take that time to really start looking after yourself and thinking about how to fill in your e-portfolio. Don't forget, it's important to book leave. It's very easy when you start to sort of think, oh, taking a holiday isn't that important. It seems sort of like a sort of less significant thing to do, but actually we all need our holidays. And with the rotas being more complicated nowadays than they were in the past, it's really important to get those requests in early. If you've got something that you really need to go to, like a wedding or something like that, really think about booking that leave very, very early. And it's not too early now if you know where you're going to. And I appreciate that there is quite a significant reserve list still this year. So as I say, if you aren't sure where you're going but do have plans, and as soon as you find out where you're going, trying to liaise with the department that you're going to be working in and seeing whether it's possible to book the leave that you might want. If it's not possible, then it may be that you can sort out some swaps, but trying to leave it to the last minute is not the best thing to do. One of the things I'd also think about is shadowing an out of hours shift. Each year, the thing that sort of is bothering people is working out of hours that first night on call. If you do a shadow shift, and you don't have to necessarily stay there the entire night, but hospitals do work slightly differently out of hours than they do in hours. And I know when I was training that I used to find that I didn't really feel familiar with the hospital until I'd done a weekend on call. So I think it does give you a slightly different perspective perspective, often people are sort of quite collaborative with each other. It's quite team spirit out of hours. So as I say, it's not all negative. It is generally a bit busier, but actually people there to support you, and it's quite nice to just sort of see how things work at night rather than during the day when there's more people obviously around, there's more elective work going on. Next slide, please. So some of the things you can sort of try to prepare for. So there's e-learning for healthcare, which has an awful lot of learning modules available to people. And this can be about how to use the portfolio or clinical work or you know, sort of managing conversations. There's all sorts of different, and there's no way you're going to be able to go through all the modules that are available to you, but think about what's worrying you and see whether doing some of that e-learning might help you feel prepared for it. The other thing I would really try and get you to sort of engage with early on in your F1 career, and even during the induction week, it's not too early. As soon as you've been given your sort of access and passwords, people rarely get into problems because their clinical knowledge and skills aren't up to speed. They're much more likely to get into problems because their professionalism isn't sort of quite up to scratch. So make sure that you do engage in terms of the supervised learning events, engaging with your supervisor, having the appropriate meetings. Actually, if you engage with the portfolio early on, you'll quickly learn what it is that you need to do. Those who lead at the last minute tend to be the ones who get into trouble. It's difficult to catch up on a year's learning, reflection, meetings, etc. So if you do it contemporaneously, you get a much more sort of in-depth view of what you've achieved. And actually, it's quite difficult to remember what you've done. I mean, I sort of do lots and lots of theatre lists, and at the end of the week, if some of the cases can be very memorable, a lot of them meld into one another, but there's almost always learning from everything that you do. And if you record that contemporaneously, you're much more likely to, at the end of the sort of placement, think, oh gosh, yeah, I remember I did that, and actually get some benefit from thinking about what it was that you learned, what you might do differently, what you do the same. It's good to record good things as well as bad things. It's not all about learning from mistakes. It can be learning about something that went really well and why did it go well, and it's generally because people communicated well with one another, worked together as a team. It's, as I say, we're civil to one another. So actually being nice to people makes the days nicer and generally leads to better patient outcomes. If you do have concerns about anything, then don't sit on those concerns. Don't, they eat away at you when something's bothering you, isn't it? Sort of you mull over and over it, and it's difficult to move on. So talk to someone, talk to your peers if it's appropriate, or if you feel it needs to go higher, talk to your supervisors. That's what they're there for. They're there to support you. It's much easier to help someone if they seek that help early on, and rather than leaving it till the last minute. Next slide, please. So one of the things that we look at as part of the survey, there's a lead self-assessment of anxiety, and I was a bit shocked in the first year that we did the survey that about a third of people who were starting F1 were actually feeling what is termed pathologically anxious, but actually that has tended to increase, and one of the things that helped it to decrease was actually doing the FY1, and you might have thought that starting work in the middle of a pandemic would not be the thing that was most likely to decrease your anxiety. Actually, were significantly, so as you can see, 29.3% of them were pathologically anxious, as opposed to nearly 41% of those who didn't experience an FY1. And I'm not saying it's all just about shadowing. It may have been that people who didn't undertake the FY1 had particular health reasons as to why they do it, or other reasons, so that may have contributed to their anxiety. But I think one of the things that we have shown, that we do a follow-up survey at about 3 months into the job, and actually the anxiety levels have decreased significantly. So that tells me that it's being familiar with where you're working, what you're meant to be doing. So take this opportunity to attend the shadowing, and it really will help how you feel in terms of preparedness. Next slide, please. So we also asked, I felt prepared for FY1. So in the cohort, we've sort of joined them all together, 2017 to 19, you can see that just over sort of 60%, probably 63% were agreeing that they felt well prepared for FY1. And then in the 2020 cohort, we've got it split between those who did the FY1 and those who didn't. And you can see again that those who did the FY1 felt a lot more prepared than those who didn't experience it. And then last year, we can see that actually the preparedness was slightly less than had been in the cohort prior to COVID impacting on learning. And I think that probably reflects the sort of changes to learning, the fact that people weren't doing so much clinical work, the lack of peer support, because so much of learning was being delivered on in an online basis. So as I say, it will be interesting to see whether we've recovered to a certain extent this year, or whether we're still impacted by the pandemic. I'm assuming it's a pandemic, but it may have been something else, of course. Next slide, please. There's also confidence in prescribing. This is a sort of slightly older slide, but basically the situation hasn't changed enormously. You can see that how prepared people feel to prescribe different drugs is actually quite variable, and perhaps not surprisingly, people feel quite confident about prescribing paracetamol and ibuprofen. They're much less confident about prescribing things like insulin. That's been sort of taken on board, and so e-learning for healthcare have put in modules about prescribing insulin. It's one of the things that during your shadowing period, ask colleagues how you prescribe insulin in that hospital. It's quite common to have to prescribe insulin. Diabetes is quite a common disease, so don't let it be one of those things that you sort of try and avoid, or sort of dread having to do. Get familiar with what it is that's needed in the environment you're going to be working with, so you can try and ensure that your prescriptions are safe and following best practice. Next slide, please. So we're moving on to think about mental health. A lot more of you nowadays will have a placement in psychiatry than had in the past, but actually people feel even less well prepared to look after people with mental health conditions than they do with people with physical health conditions. So again, if you're starting in psychiatry, or if you have a psychiatry placement during your program, then you really do take the sort of benefit that you gain in terms of experience from that placement, and learn about the sort of how to look after people with mental health conditions, but also how to prescribe them. An awful lot of people are going to be on drugs for mental health condition, even if you're working in a non-mental health setting. But actually an awful lot of physical health and mental health do overlap with one another. So as I say, more and more people do get that opportunity, and try and make the best of it. It isn't just about fulfilling that particular placement. It will really help you look after people when they have physical health conditions in an acute setting or in the GP practice, because as I say, there is so much crossover between physical and mental health. Next slide, please. So do attend your mandatory induction week. Each year we get the odd person saying, well, I've got a wedding, or I've got a holiday booked. Say, I know, say you're not necessarily in charge of when other people get married, but really, say, missing that week is a sort of silly thing to do, if at all possible, because it's the time when you meet your peers, it's the time when you can ask those questions, it's the time when you get to talk to the outgoing F1. There's no other opportunity really where you're going to have a week where it's all about just learning about how to do the job. So I say, don't miss out if at all possible. Next slide, please. So in summary, try and make it as easy for yourself as you possibly can do. Try and do what you can to do some learning, attend the shadowing, ask all the questions. You might think they're silly questions, much less silly than the next week when there's no one to ask and you just do something because you think it's the right thing to do and actually make a mistake. it's always possible to ask. There are always going to be people around. Don't forget that the nursing staff are a fabulous resource in terms of education. They're going to be much more familiar with the environment than you are. They're probably going to have worked there for some time. Say if you ask them, they'll almost certainly going to be pleased to help you. And if you sort of think of them as, oh no, they're a nurse, they won't know the answer, then you're going to build up that barrier. Again, the crossover between what nursing staff do and what the doctors do nowadays is far sort of less than it was in the past. So a lot of skills that we have, they also have. So just say, if you're not sure, what do I do? Who should I ask if they don't know? So they're here to help you and look after the patients safely. Don't forget to document anything you do. If you document, it really does help you. I gave a little scenario last year in this, that I was emailed one Saturday when I was on call, and I thought, I can't remember that case at all. It was about someone who had come in and died in ED 7 years before, and I was really lucky. I sort of looked through the notes from 7 years ago. I had lovely notes recorded by an excellent trainee who had asked me to go along and help when they couldn't intubate a patient. I mean, actually, I was so pleased to see Guy's lovely clear notes and say, you never know when you might want to look back and find out what it was that you did at that moment. And actually documenting at the time is a godsend, and as I say, is never a bad thing to do. And then just lastly, I'd say don't forget that you are an employee too. People have all sorts of sort of different things that go on in their lives. If you need to take time off or whatever, just communicate with your department, communicate with HR. If you need to present fit notes, then do so. If you don't talk to people don't know what's going on. So they then don't engage with you. The sort of barrier gets set up, and instead of everybody wanting to work together to help you, there seems to be a sort of bit of a sort of negativity. So just talk to people. It's very unlikely if you talk to people and ask for support that you'll ever be refused. So on that note, I'd just like to say good luck for your future. If you know where you're going, great. If you don't know where you're going, don't panic. We'll still be able to support you, and people are being advised to try not to put people on call if they're being given their rotations late too early on in their jobs. So very best of luck.
Thank you so much, Claire. That's so many pearls of wisdom in what you say there, and I echo absolutely all of it. So thank you so much. I'm going to just run through a few things now. I should apologise to Claire. I was very slow going through your slides. It was my IT, not me. But there we go. And my first slide is this, and I just wanted to say again how helpful it's been to hear from Claire. And I'm going to develop a few of those themes in the next few minutes and talk about some of the things that we at the MDU think it would be hopefully helpful for you to know about and think about as you start F1. And one of the points that Claire made is the importance of seeking opportunities for learning and development, not just from things that went badly, but things that went well, and the importance of reflecting. I'd absolutely echo that. And do take all those learning opportunities that you can. A lot of learning comes from incidents that aren't planned. They're not part of a teaching session. They're things that just happen. And anyone who's looked at our foundation guide that we've put together in advance of this session will see that illustrated with some scenarios. And you are going to get a link to that in an email follow-up to today. I thought for the next few minutes it would help to go through a scenario where something did go wrong for the doctor, and just to illustrate really the power of reflective learning and how that helped a doctor get through a really difficult situation. Errors are part of human life. They do happen. And so I hope you'll forgive me for talking about a situation in which there were errors. That's not to say you know, I'm expecting you to get into difficulty. Hopefully not, of course, but I think it's important to be prepared by just thinking, how would I approach something if something did go wrong? I should say that we need to be as careful about confidentiality at the MDU as you are as doctors. So this is a fictionalized scenario, but it's based very much on the sorts of things that we see. And it brings out a lot of the sort of things that need to be part of your practice that Claire's talked about: good communication, professionalism, good record keeping, and confidentiality. So here we go, the scenario. And the doctor concerned in this scenario was a foundation doctor on a surgical ward. And the situation was that on the evening's drug round, a patient had been given the wrong medication. Now, it wasn't that the doctor had made an error in prescribing. The prescribing was fine. It was an error in administration. So the nurse who'd made the error recognised immediately what had happened and asked the foundation doctor to come and assess the patient. And the patient had been given a drug they shouldn't have had, that the doctor recognised as an opiate, but didn't really know much about that particular preparation. Knowing it was an opiate, though, the foundation doctor went and assessed the patient and was looking for opiate toxicity, and found that the patient was conscious and their breathing rate was fine. So they weren't too worried. Asked the nurse, please just keep an eye on the patient, but then was called away and didn't write anything in the notes and forgot about it, and forgot to mention it at handover. Unfortunately, it was a long-acting opiate preparation, and later on the patient had a respiratory arrest. Fortunately, did recover after resuscitation. The nurse filled in, quite rightly, an incident form about the drug error. And the doctor was asked for a statement because there was to be a trust level investigation. And that doctor was understandably really upset about what had happened, and was really worried that she might be criticised for not having known that medication. She had asked the nurse to keep an eye on the patient, but would that be enough? She didn't know where to go for help or quite what to do. Would it be worse if she admitted that she hadn't known what that medication was? Well, this next slide is just to illustrate what I mean by multiple medico-legal jeopardy, which is relevant here because it's just to say that one single clinical incident can give rise to so many different sorts of investigations. We're talking about a trust internal investigation in this particular scenario, but particularly where a patient's died. Fortunately, this patient didn't. There can be many different sorts of investigation. So I put that there just to illustrate the sorts of things that can happen, from claim for negligence, NHS complaints, obviously, occasionally GMC complaints, inquests, etc., etc., etc. And often the first step is when something goes wrong, the doctor will be asked for a statement. So it's really important to sort of think that through and get that right, and to think carefully about the initial response to an event. So the two sort of what happened next sliding doors versions of this scenario. The first version is what did happen and it all worked out fine, and then there's a much worse sort of what could have happened if the doctor hadn't approached it so well. So what did happen? Well, the primary error here was somebody else's. It was the nurse who'd inadvertently administered the wrong medication. But there were problems in what that doctor had done. There was a bit of a knowledge gap in not knowing what that medication was and actually not looking it up to find out. And so that illustrates the importance of getting some help if you're not sure about something. There were some problems in communication there. The doctor did ask the nurse to keep an eye, but that's not very specific. And the doctor forgot to mention it at handover. And also the doctor forgot to keep a record. And as Claire said, it is really important to keep a note of all assessments you make and of everything you do, really. So the doctor was upset, and it is a shock to be involved in something where a patient could have died and it was such a near miss. Unfortunately, in this scenario, the doctor called us to have a chat through. Now, you don't have to call the MDU. You may be people listening here who are not in the MDU or join a different defence organisation, that's fine, but do call to get help wherever you're going to get it. It's our only job is to help you. So please do, if you're an MDU member, call us if things go wrong. And it's vital to look after yourself as well. So if you just feel really awful, then get support from your peers if that's appropriate, and your educational supervisor, etc. But when this doctor called us for some medical legal advice, the advisor will have reassured them that mistakes are human, but it's important to approach it in a way that's open and honest. And a good first step would be to have a discussion with the supervising consultant, with the educational supervisor, and to take some time to reflect on what had happened. Not just the obvious point about not having known what that medication was, but the bits about communication too and record keeping. So the doctor did that, wrote a statement and also a reflective piece, and the educational supervisor was supportive, and the trust investigation went ahead and made some sort of recommendations generally for education, but nothing specific or difficult for the doctor, and the doctor got support and stayed well. So these are the points: to please take advice and get some support, be open and honest, and make sure you're being seen to reflect and learn if things happen. But in Sliding Doors version 2, this doctor didn't get advice, was really upset, but kept that distress in and just felt horrible about it. Decided not to admit that she hadn't known the drug name because she was worried that would make things worse, and in a moment of panic went back into the records and added a note that's to say that she'd asked the nurse to do OBS every 2 hours, which wasn't accurate. And then, to add even worse thing to do, the doctor went home and started to feel really angry that somebody else's mistake had really led her into this awful situation. And she went onto social media and had a bit of a rant about the nurse in a post that didn't name the patient, but did inadvertently identify the patient because they had quite an unusual condition. So the doctor in this version of the scenario, I'm sure you can imagine, faced a really different set of consequences, because that sort of reaction to an adverse event raised lots of questions about that doctor's professionalism. That there was a lack of reflection and learning there, and a very dishonest approach in how she dealt with the records, unprofessional in what she'd said about the nurse on social media, plus an inadvertent breach of the patient's confidentiality. So that doctor could face really some serious criticism, and those sorts of situations, we see them unfold in a way that unfortunately really does, threaten careers. Which is why I'm telling it as a cautionary tale, and hopefully nothing like that will happen to you. But if you do get an adverse incident happen, don't panic. Get the support that you need. Don't be afraid to be open and honest about what has happened, any error or lack of knowledge. Don't be afraid to say sorry. It's just the right thing to do. Do reflect and remediate, and do just make sure that you're acting professionally at all times. Now, one of the issues in that scenario was confidentiality, and the doctor had inadvertently breached confidentiality there. And you talk in your training, we talked to you about the sort of interesting ethical conundrums of whether to breach confidentiality for the public interest, etc. But most breaches of confidence are actually unintentional. And maybe, having done some of your training in the pandemic, when there are fewer people around, you might be less used to having to be super careful about things like not being overheard in the canteen, not leaving screens open, not leaving notes where they can be seen, all that sort of thing. Emails to the wrong person are obviously just a hazard of everyday life, but be very careful if you're emailing people about patients. And social media, that could be a whole nother talk in itself, but be super careful on social media. And it's best to keep personal life completely separate, I would say, from work. But we can talk about that in questions if people have got particular concerns about it. So this is something that we brought up at the beginning, and Hannah mentioned hasn't been covered really through practical experience in training. What about talking to those close to your patients? This is something that's likely to come up very early in your career. And essentially, of course, you've got a duty of confidence to your patient, but you've also under a duty to be sensitive and responsive to those close to your patients. So it's important to establish, if you can, what your patient wants and abide by the patient's wishes. And it's good to have a conversation, or for someone to have a conversation really early in a patient's admission about who they would like staff to talk to and who they might prefer staff didn't give any information to. If the patient lacks the mental capacity to make decisions about that, then it is reasonable to assume that they would want those close to them to be kept informed unless they've indicated otherwise. And as with everything else, do keep a note of who you speak to and the main elements of the conversation. Another thing that came up in that scenario is writing a statement. And as a foundation doctor, you might find that you're asked for all sorts of, or one of many, many sorts of different statements. And there are a few examples just going up on the screen. We've got some guidance on our website about writing statements, and you're always welcome to send drafts in or call us for advice. But I would say just the main thing to have in mind is that the GMC guidance reproduced here, just to make sure if you're preparing to sign anything or you're writing something, make sure that you take steps to check that what you're signing is accurate, and you mustn't deliberately leave something out that leaves whatever you're signing as being misleading. We do see doctors get into difficulty sometimes trying to help patients by writing letters or signing things that really on reflection they wish they hadn't. For example, if a doctor signs a letter to say that a patient isn't fit to attend court, then that doctor might find themselves being called to that court to explain to the judge why the patient isn't fit, which is fine if you've got the competence and to actually be making that assessment and you're prepared to do that, but do hesitate if somebody asks you to write that sort of letter, or indeed do hesitate if someone asks you to write to whom it may concern. It's much better to find out what they want the letter for, who it needs to be addressed to, and that'll help you judge what the letter needs to be. And if in doubt, just call us for some advice. Right, last things, just some things to remember about your registration with the GMC. Your provisional registration, which hopefully you're all applying for or have already applied for, is just for your first foundation year. You need then to apply for full registration with a license to practice for your F2 year, or for any unsupervised practice. But there's this extra thing that's not so well known, which is until you've had your first revalidation, which is probably 5 years, you need to be in an approved practice setting. So that's basically NHS trusts or places that will support training. And you must have a connection always to a designated body, and it's your responsibility to make sure you meet those requirements. So if you're offered interesting things to do, like go and be a doctor at an event or whatever else it might be, do ask your educational supervisor whether they consider that that's suitable for you at your stage of training with your level of competence, and do make sure it fits with the APS approved practice setting requirement. So that's all I was going to say there. We're going to have time for questions at the end, and now I wonder if I could invite Dr. Laura White to give us her talk.
Thank you very much, Catherine. So hello everyone, my name is Laura and I'm currently an internal medical trainee, or what we used to call medical trainees, up in the Northwest, and specifically I work at Bolton. Now I'm going to talk to you from a point of view of a junior doctor who's been through this in the last few years, and it can be a really daunting process going from being that final year medical student to a foundation year 1 doctor. Suddenly you have all that responsibility sat on your shoulders, and what we've already gone through, we've had some really good tips, but I'm going to talk from a perspective of a junior doctor of what I wish I had known when I was starting. So next slide, please. Okay. So the first and most important thing I really want to get across is how useful the induction period is. Now, I will confess that when I was a foundation year 1 doctor, I thought, oh, brilliant, I've got to start work an extra few days early. I hadn't planned for this. Why are we doing this? But in hindsight, the induction period was the most useful period of time I've had in my entire medical training so far. And the reason for this is, no matter how long that induction period is, it's the only time in your medical career that you are going to be supernumerary. And by that I mean you're an extra person. You actually don't have any responsibility during that induction period. You are still officially a student, but you are able to go on the wards and shadow your future roles. So when I was a foundation year 1 doctor, and when you go on to do this, you will go on to the placement that you are due to start, whether that's for a few days, for a week or 2 weeks. It can be dependent on your local trust, but I'd recommend doing as much of that as possible. And that is because you quite literally get to shadow the job you are going to be doing. And it really helps get that familiarity. So that first day, which can be really scary, I remember how terrified I was going into my first day of work as a proper doctor, as I called it. But having that 2-week or however long you get a period is useful to help settle those nerves. So what sort of things would I suggest doing during that induction period? Well, the first point I've said there is get as much experience as possible. And by that I mean shadow the junior doctor that you're going to be following for the whole year. So you'll have your fellow colleagues be on tracks, so you'll be able to find that colleague. Shadow them on a ward round, see how they write notes and ask, can I write a set of notes for this ward round? But make sure if you do anything like that, that you have it countersigned by a clinician, because remember, during your induction period, you are still classified as a student until that first Wednesday. Other things I'd recommend doing is I'd recommend going on call shift and see how your colleagues structure an on-call. And I'll talk a little bit more about on-calls shortly. But I'd also ask them, how do you use the prescribing system at this hospital? Where are all the medications kept? Where are all the procedure stuff kept? So as an FY1, you will do hundreds of blood tests and hundreds of cannulas. So you need to know where that stuff is. And that's all things that you can do during that induction period. And as I've already alluded to, shadow those foundation year 1 doctors. That is what you are going to be doing. And I'm sure lots of you have been doing that as a final year medical student. But we know training, particularly for your cohort, has been impacted over the last couple of years. You have trained and learnt through the pandemic. So you may not have had as much exposure as I would have done as a final year medical student and during my clinical years. So I really recommend doing as much as possible during that induction period, essentially acting as if you are a junior doctor, but obviously remember you are not, and anything you do, you must do in under supervision of a junior doctor, whether that's a foundation year 1 or a more senior doctor. And if you do write in any notes, you get that countersigned. And the final thing that I wish I'd known about when I started as a foundation year 1 doctor is that pretty much every hospital has a WhatsApp group or something that has a load of inside tips. And again, we'll talk about being careful, and Catherine's already alluded to being careful when you're talking on social media and in these WhatsApp groups. But inside tips, I know when I started at my current hospital, a previous doctor sent me every single code that I would need in the entire hospital. So that's code to get into the pathology lab so I can send my blood tests off. That's code for all the different pod systems that we have to send off bloods, but also the codes to get in all the different wards. And that will make your job so much easier as a foundation doctor. So ask your current trainees, what are your big tips? What should I do to get through these next couple of years in this hospital? Next slide, please. So the thing I worried about the most, and I'm sure it will be something that lots of people worry about the most, are those on-call shifts. And on-call shifts, particularly those first few ones, can feel really scary and daunting, but I promise you, you will settle into it so easily, and you'll look back in 12 months' time and be like, this was so much easier than when I first thought about it. But we know some of you are going to be on call pretty soon from starting, although I know the foundation schools are trying to encourage those who get their jobs later to have that push back to give you a bit more experience. But I was that foundation year 1 doctor who was the first doctor on call on that first weekend. So I'd certainly felt slightly overwhelmed. And these are some tips that I'd wish I'd known about before I'd gone into that first on call shift. And the biggest thing that I can say is be organised. Now, we get that drummed into us throughout medical school, but being on call, being organised is key. And I would really encourage you during that induction period, shadowing your fellow F1s to see how they organise their list, from whether that's handover from other colleagues or handovers from nurses. If you have a bleep system at your hospital, that bleep can be overwhelming. So you need to have a good record of the information that you've been handed over, either by a doctor, a nurse, or sometimes physiotherapists and other allied health professionals. And you need to know that on a piece of paper so you can prioritise who you are going to see. And that organised list not only gives you chance to see what jobs you've got, but again, that prioritisation of what is more clinically urgent. And both of those things you can get from shadowing those FY1s, which I'm sure you've done at medical school, but particularly during that induction period as well. The one thing I would say, and the nicest thing about hospital medicine, which is why I enjoy hospital medicine so much, is you are in a team. You are not on your own when you're on call. And myself, as going into the medical reg role next year, I expect to be called every 10 minutes by the FY1 on there for those first few shifts. That doesn't matter. We want you to contact us. We want you to help and to seek that help. You are not expected to know everything, and that is why we work with you as a team. And those scenarios, some of them can feel quite daunting when you're going to see unwell patients, but that is why you have senior clinicians there, and you will learn loads through those on-call shifts the more you ask for help. Don't feel you just have to ask questions about clinically unwell. Ask silly questions like, how do I prescribe this medication? When should I be prescribing? Who do I ask for help? And that's one thing I would say is during that induction period, again, is learn how to refer to other specialties. Every hospital will be different, but as an FY1, you'll spend a lot of time referring to your possibly surgical colleagues or other specialties within medicine. So know how to do that and know how to use that bleep system before day one. And the final thing is a little bit of a thing that I wish I'd learned a lot earlier in my career than I have now. But if a nurse, a HCA, anyone offers you food and drink, please say yes. In order to make good decisions on an on-call shift, which are long shifts, they're often 12.5-hour or longer shifts, sometimes when you have to finish off a handover that's taking a long time, you need to be hydrated and fed in order to make those decisions. Often it feels like you don't have time to do that, but unless you have got a critically unwell patient or you're at a cardiac arrest, there is time for you to have a glass of water and a sandwich. So if anyone offers it to you, take it. So next slide, please. And finally, something that I felt wasn't really covered at my medical school before I started, which is why I wanted to cover it here, is your portfolio. And as a foundation year doctor, you have the Horus e-portfolio, which does change as you go on into specialty training. And again, I would reiterate the point that Claire made earlier of getting onto those learning ELFH systems in order to learn about your portfolio and how it works. But I would say get onto the Horus e-portfolio and Foundation School website early and know what assessments that you have to have for every placement, and don't leave it till the last minute to get those things signed off. Make sure from day one you're saying to your senior clinicians, can I send you a form to have this signed off? Can I get this clinical experience in order to be able to sign this thing off? As an FY1, when I was an FY1, you had to get 15 clinical procedures done. I managed to, with proactiveness, get all of those done within my first placement. And that took a big weight off my shoulders when I was going into the ARCP, or annual review of competencies, which every single doctor in training goes through each year. I would also recommend that when you do look at these requirements, if you're not sure what any of it means, speak to your clinical and educational supervisors about what you need to do to complete those requirements, but also thinking about your future career, because some of you, I mean, I'm sure a lot of you will want to take a career break in the Foundation Year 3, but some of you will want to go on into training straight out of Foundation Year 2, which is something that I did. And that means you need to be building your portfolio for that application right from the start of Foundation Year 1. They are competitive applications, and the more you say yes to opportunities that you're offered to, within reason, obviously keep that work-life balance in the background, it helps build a varied portfolio that you can take to an interview and show and be very proud of. So next slide, please. The final thing I just want to talk about, and something that I've added in this year, is about your future career transitions. Now, you're going through a big transition now from being that final year medical student to a Foundation Year 1 doctor, but you're going to do a transition again next year where you go from a Foundation Year 1 to a fully qualified Foundation Year 2, or what we call a senior house officer. And with that transition, again, you are going to have added responsibility. In addition, you then move on to a core training specialty, whether that's GP, obstetrics and gynecology, surgery, medicine, all of those. But again, that's another transition point. And the Foundation Year 1 transition point is by far the nicest. You get a big induction period. You have all the time in the world to ask all those questions and learn about your hospital. But that doesn't happen in your future career transitions. Again, what I would suggest is know about your portfolio requirements really early on and get started early, the same as I would as a Foundation Year 1 doctor. But the big thing that I would suggest is get to know your hospital. So when I started core training, I went to a completely different hospital that I'd never been to, and I was on call on my second day. And when you're a more senior doctor, it is expected that you will understand how a hospital works and be able to fall into that role. So be proactive, organise and speak to your future hospital about coming over for half a day or even a day to familiarise yourself with that hospital. Now, yes, they should provide you that, and there is, as we've already mentioned, legal requirements for them to do that, but often those induction periods can only be half an hour, an hour. It's not enough time to familiarise yourself with that hospital. So be proactive, seek out opportunities to go and learn about that hospital. It's something I did before I started core training, and it's something I'll be doing again next year before I start my first year as a medical registrar. And again, I always say this throughout your career, think about your future. It doesn't matter if you don't know what you want to do. Things like being involved in quality improvement projects or writing up special cases, if that's something you're interested in, will be relevant to any application in the future. We love it when people are interested in our career, but you don't have to be interested in every single one. But showing engagement and willingness is something that as senior doctors we love to see, and we're always happy to get foundation doctors involved in that. So next slide, please. So really, that's all I wanted to say. And I just want to say, remember, you are always part of a team. As senior doctors, we are always there to support you. And this was me at the end of my foundation training at Royal Oldham. And every single name on there was somebody I worked with in the pandemic. So it is not just a single person that runs a hospital. So you don't have to be as a foundation year one doctor. Thanks very much.
Thank you so much, Laura. That was amazing talk. I thought there was so much useful information in there and so many hints and tips. Thank you. Now I'm going to stop showing the slides now, and hopefully we can all turn our cameras back on and move to some questions. John has been looking at any questions that have come up in the chat and will come to us as a panel in a minute. But before we do that, I was wondering if Hannah or Aqua might still be there. Yes, good. Hello, both of you. I hope you found that helpful. Hannah, I'll come to you first. Have you found that helpful, and have you got any particular question that you'd like to put to all of us as a panel, or any one of us in particular? You can't unmute yourself at the moment. I don't know whether we can unmute you. But while Christian is helping with that in the background, Aqua, I wonder whether you might have a question, if you can unmute yourself.
Yeah, can you hear?
Yes, thank you.
Awesome. So I am, I guess, whilst I may, be comfortable in the hospital that I'm going at, I am worried about my upcoming surgical job, where supposedly I'm hearing from my senior colleagues that I might be managing at least 4 or 5 wards during an on-call shift, and I'm worried about being the only doctor on the ward without senior support. I guess, will this happen? And I understand you gave so many fantastic tips, but we will have this, and I guess it is anxiety inducing. Do you have any tips?
I wonder, Laura, if you'd be the person to speak to that first.
Yeah, no, so on-calls can be really overwhelming, and you suddenly go from possibly on a day job having 10 or 15 patients to suddenly 5, 6, 14 wards at some point, potentially working with your colleagues. But what I would say is about being that organised. So get a list. The way I get a list is I have an A4 piece of paper, I fold it up 4 or 5 times, and it's got 16 little boxes on it. I have those 16 boxes, and each time someone hands over or bleeps me, I put the information in that little box. When I've completed the little box, I put a highlighter over it. So I don't use a pen, because you never know, a nurse or a doctor might bleep you about that person again, or you might end up having to hand that person over. So that highlighter tells me I've done what I need to do for now, but if I need to refer back to it, I can. And again, having it in a nice big square format in front of me, I can go, oh, that person sounds a little bit more poorly, that thing doesn't. And again, during that induction period, I would look at your colleagues, see how are they organising it, how are they deciding who to see. Now, I know lots of people always worry, well, what about if I'm on my own? But remember, you're not on your own. Even if your surgical colleagues are in theatre, if you're really worried about a patient, there is the cardiac arrest team on 2222 in every single hospital. or you've got the senior medical team, and we are always happy to be contacted, particularly by surgical FY1s if their patients are poorly. We know surgical patients get really, really sick, and sometimes your seniors are in theatre. But again, it's not just the surgical team is one, the whole hospital works together. So always contact, and if you're ever really worried and you feel you're on your own and someone's really sick, I just put the 2222 call out. We're never going to be unhappy in that situation. All right.
Thanks, Laura. That's great. You are not alone. Claire, have you got anything to add to that before I see if Hannah has a question?
Yeah, I'd absolutely say you are definitely not alone, and don't forget your team will have a consultant who's on call, and as I say, consultants are not beyond being called. As say, anaesthetics has probably got a very non-hierarchical structure, and as I say, we're certainly not against being called. People get far more upset about finding out that something went wrong and they had no idea. They were at home, they had a phone in their hand, yet they could have been contacted. It's much better to get a call and be able to reassure someone than get a call and find that, you know, actually something's happened. You weren't aware that anything was evolving, and you know, there's a fait accompli that you can't do anything about. Your seniors are there as part of the team. They are not someone who is outside the remit of being communicated with.
Thank you. Hannah, can I come to you? Do you have any questions for us?
Thanks for all your talks. They were all really useful. I just wanted to ask, sort of from an MDU perspective, what you think the most common errors are that are made by F1s and how we can avoid them if possible.
Oh, that's a really good question. I think John will echo this. It comes down to the C's of consent, confidentiality, but maybe the biggest C is communication. And this goes back really to what we were just hearing from Laura and Claire. It's about communicating as a team. And where we see people get into difficulty tends to be where they haven't communicated very well. So missing handover, being late to handover, not sharing things with colleagues is a big one. In terms of commonness, I haven't looked at the stats, but that's certainly, I would say, a big takeaway message is focus on communication and handover. Thank you very much to Aqua and Hannah. I wonder, John, if you could let us know if there are other questions that people have been asking.
Yes, well, they've been fantastic talks, so we've got some great questions as well. Perhaps I could start one off to Claire. Somebody's asked about the questionnaire that you send to FY1 doctors, and whether the results of that go back to the medical schools, particularly on the prescribing, if that's a concern that's raised F1 doctors.
Yeah, sorry about that. I've got my iPad balance and I've just managed to unbalance it, so I'll try and hold it relatively still. Yes, so it's anonymous in the sense that I don't report anything that has less than 5 respondents, but each year I send via Medical Schools Council the results split by medical school to each of the medical schools, and actually it has had an impact. I mean, one of the sort of issues in terms of prescribing, it was very much used as part of the support for bringing in the prescribing safety assessment. The fact that prescribing was such a significant sort of problem, if you like, in terms of confidence for the incoming F1s. So yes, I do share it, and it has had an impact. So again, I'd just say, do please fill it in. It is useful in terms of actually getting stuff done. The other thing I'd say, just in terms of the comment about common mistakes, prescribing is a very common area for making mistakes. One of the best things that's happened to my life is the BNF app, and you don't have to have Wi-Fi when you're using it. If you download it, it's BNF, for children and adults, and any drug you're not familiar with, you can just type it in and sort of find out what its indications and dose size. It's really difficult with all different names, different sort of in sort of when I qualified many moons ago now, most of the drugs that were at least familiar in terms of class, the beta blockers had an ol at the end, so we could probably work out what it is. Nowadays many of the drugs actually don't have that very easy reminder as to what category they're in. So as I say, look it up, because it's much easier to look it up and sort of see what interactions might sort of be problematical, rather than hoping and then finding out sort of that actually you shouldn't prescribe something, or something you prescribe's got an interaction.
Fantastic. Well, Claire, you answered another question there as well, because there was a question about a useful app. So you've named one there as well. Just going to Laura, we've had a couple of questions on nights and how do you prepare for nights? So I can remember one of my colleagues when I started as an F1 doctor, got there on their first day and they were told, actually, you're on nights today, so go home and get some sleep. So I don't know whether that still happens now, but how do you prepare for your night?
Yeah, so I think nights is a really individual thing, and you'll settle into a regime. I mean, I'm in my 5th year of being a doctor now, and I'm just about settled into a regime. But the way I do it is I get up at a normal time. So I normally get up at 6:45 a.m. and I get up at 6:45 a.m. I then somewhat knacker myself out by about 2 p.m. and that allows me to sleep for about a 3-hour nap. So I allow myself about a 3-hour sleep in the afternoon. That again settles your body into the idea that it needs to sleep in the day from the next day. But I do that with blackout curtains and an eye mask and a completely silent setting. So if you've got other people that work from home in your environment, tell them shut the doors and get headphones in as well. Do whatever you can to set up a nice sleeping environment, and then get yourself through that night shift. But if you don't feel safe to drive home, please tell someone. So if you really do feel unsafe, the hospital can provide an emergency on-call room that should be available to anybody, or they can otherwise order a hospital taxi for you. So there are arrangements that can be made, but if you're like me and have to do a 45-minute drive home after that first night shift, that's when you're the most tired and things can go wrong. So make sure you've got a backup plan if you do feel too tired.
And we touched on it during one of the talks. I think it was Catherine. You were talking about social media. I think Aqua, you were discussing about your WhatsApp group. Somebody's asked about whether you can talk about patients anonymously. So learning from others, can you do that via a WhatsApp group?
You have to be so careful, and John, you like me will have seen cases actually that revolve around this, and it wouldn't be for us to talk about particular applications, but just talking about social media in general, both the messaging social media apps and the ones where you post things. Both of them, and any other social media, can potentially be a problem. There is GMC guidance to look at on their website, which specifically warns doctors to be careful, because even if you don't use patient identifiers, then giving small bits of information about patients can identify them, either because you're giving different little bits of small information that can be linked, or for example because it's a patient with an unusual condition. And even if a patient can only identify themselves and really nobody else can, that's still a problem. We do see people getting into difficulty not only identifying patients, but also posting things or that may be deemed by others to be unprofessional. So do just be extremely careful. Have a look at the GMC guidance. And I would say if there are sort of group chats on social media that people use at work, then just be really careful that you're not posting any patient information. And actually your workplace should always have an IT, well, they will have an IT security policy, and you need to make sure you're not breaching it, and check whether it is within your workplace's IT policy that you are allowed to use, what social media you are allowed to use, if any. So just general note of caution, I would say keep work and home completely separate, and preferably don't post anything even vaguely about patients anywhere near social media. But I know I sound like a dinosaur saying that, but please be careful, because we genuinely do see people getting into difficulty.
Also, we've had some questions about rotations and shifts in terms of whether you can swap them. So this might be a question for you, Claire, that you can answer. So I think people are asking about the rotations they've got. What's that? Is there a way of swapping them? And also, if they are allocated on-call shifts, is there a way? How best do they go about swapping those?
Okay, so the things are sort of slightly different. So in terms of the programs that you've been allocated, I believe that most foundation schools effectively allocate those programs using the ranking, and then stick with the policy that actually it's a meritocracy. The programs are put together to be balanced programs. So asking to swap a single placement as part of that program is not necessarily appropriate, and it therefore becomes a free-for-all if you start swapping placements. And it seems to the two people who might both want to swap a placement perfectly reasonable, but actually if you allow that to get out of hand, you can effectively get one person putting quite a lot of pressure on someone else to swap a placement. So most foundation schools run some sort of swaps process between F1 and F2, which enables to a degree a little bit of flexibility. Obviously it's reliant on people putting in their own programs to be swapped in order to be swapped, and I think one has to be realistic that if you have been allocated to a program that you feel it's very unlikely that anyone else is going to want, then it may be unlikely that you're going to be able to swap a program, particularly when the program has been very oversubscribed this year. So I think it's just, you know, being realistic, but also realizing that actually there's lots of learning in whatever program you're going to be allocated to. It might be nice to experience the career placement that you're planning on, but it's certainly not essential in terms of demonstrating a commitment to career. There are lots of other ways that you can do that. So I would embrace whatever you've been allocated to. It may well be that the thing that you thought you most wanted to do actually turns out to be the thing that you don't like, and you know, vice versa. So I say try and keep an open mind, and actually you'll probably find it's a much better experience, and will give you all the curriculum needs that you have to fulfill, rather than mithering away about wishing that you could be doing something else. The grass isn't always greener, so I would probably just try and embrace what you've been allocated to. In terms of swapping shifts, most places will allow swapping of shifts, but it isn't for you to swap that and not let anyone else know. The trouble is when people do a lot of swapping around, sometimes it means that IT and the organisation isn't aware of who's meant to be there. It's really important that when people are meant to be in a particular location, if they swap that with someone else, then everybody who might need to know is aware that that swap has occurred, because otherwise people can be trying to contact someone in an emergency and actually they're trying to contact the wrong person. So swapping of shifts is probably okay, but you do need to ensure that it's not just between you and the other person, that everybody else in the department is made aware.
Thank you, Claire.
John, I can see time is marching on. I wonder if we might have time for one more question, potentially, if there are lots more.
Yes, I could perhaps group a couple of questions into one question for Laura. It's about those the participants who are going to other trusts that they haven't been trained at. Any top tips for them? Will there be opportunities to meet with other F1s outside of work? What's your experience, Laura?
Absolutely. So I'm one of those people. I trained at University College London and then made a bit of a big decision to move myself completely up to the northwest, and I didn't know a single person when I got up here. So one thing I would say is get yourself, when I started, Facebook groups were a thing. I'm not sure Facebook is still a big thing now, but get yourself, whether it's a WhatsApp group or a Facebook group, introduce yourself. It feels horrible, but introduce yourself, say who you are, and you can make friends. Often the foundation year 1 and 2 groups are really close. And I know at Bolton, they go to teaching together so they can get to know each other. I found someone to live with through the WhatsApp and Facebook groups who I didn't know, but was a foundation doctor at the same school. And also, typically foundation year 1 and 2 doctors share all the inside tips between each other. I get most of my inside tips still as a more senior trainee from the foundation doctors. They are the people with the ears to the ground, they know everything. So you're normally a really close-knit group, and there's lots of social stuff that goes on. Join the doctor's mess as well. That's a good way to socialise among people.
Thank you. Thanks, John, for putting those questions to us. Thank you all. And Laura, I'm sure you'd echo this as well. If you're busy making friends and you spot somebody who's the shy person who hasn't felt able to reach out, try and get them involved as well. I'm sure that everybody would. So thank you all. Thank you, Claire. Thanks, Laura. Thanks, Hannah and Aqua very much, and John. I'm going to round it off there and we'll finish the webinar with huge thanks also to our behind the scenes organisers and to all our participants. So thanks all very much indeed. Take good care.
Thank you.